J'espère que vous serez là pour les versions du bâtiment aussi.
Vous allez au village de André voilà. Mon vieux téléphone. Mon vieux téléphone. Il est tellement
Morning.
Ça va bien? C'est quand même trop bien servi. Vous surveillez. Parce que...
Good morning, everyone. Good morning. We are going to start. So I'm Bénédicte Pensier, the director of Les Pensières Center for Global Health. And on behalf of all the team, I would like to warmly welcome you to Annecy, France, and to Les Pensières, to our center. I would like also to say hello to all the people who are connected. We wish you could be with us today. Last time there was a Gabrielle meeting, was in 2017. So we are seems a long time ago, and we're extremely happy and honored today to be able to host this Gabrielle meeting. You are more than 50 people in the room, and this is quite impressive. You are coming from more than 15 countries. And we are so thankful and grateful for you. You've been able to make it. I know some of you have been long trips. You had to go to all through the PCR test and so on. So thank you for being here. It's a true honor. I would like to thank my colleagues at the Mérieux Foundation. So Florence, Marie-Charlotte, Marc, for the organization of this meeting. It's a true pleasure to work with you. So some of you have been here many times. They are friends and they are even part of the family. But for some of you, it's the first time. And so we thought that maybe I could say a few words about this place, about this venue, about this center. So you're here at the Mérieux Foundation. So this foundation, as you know, was funded by the Dr. Charles Mérieux in 1967. And the mission of the foundation is to strengthen local capacities to fight infectious diseases in low and middle income countries with a focus on the most vulnerable population, so the mothers and the children. So my colleagues will say a few words about the foundation and in particular our scientific and medical programs. But here, it was a family house. Charles Mérieux's wife, so Mr. Mérieux's mother, was from Haute-Savoie, and she loved this place. And when she was little, she came by boat. You could see some pictures at the coffee break, where you could come by. All of this was covered, it was vineyards. And she would have said to her father, I love this place, and I would love to live here when I'm older. So the family bought this property in the 50s, and it became their summer house. And a bit similar to what you're going to live in these 3 days, The doctor is someone who always combines his professional and personal life, inviting people from around the world in a multidisciplinary approach. So with people from animal and human health, you know, combining the disciplines. So medical doctors, but also vets and pharmacists and scientific people and people from the ground. And he saw that there was something, you know, happening. He saw the power, the good vibes of this atmosphere to create new collaboration to advance global health. And so the center was created over the years. First of all, he renovated the old barn, he created a conference room, and then he created a restaurant and some rooms to be able to host his guests. This room, which was fully renovated during the COVID, to be able, you know, it's fully equipped now to be able to have the hybrid meetings and to be able to connect with people around the world. And when he passed away, it's his son, Mr. Merieux, who took over, who also had a new building. And the family decided to bring to the foundation the whole property. So we now belong to the Merieux Foundation, and this center is strongly aligned with the mission of the foundation. And one of the strategic mission of the foundation is to promote knowledge sharing and exchanges in a multidisciplinary approach to advance global health. So this is the mission of Les Pensières, to be able to foster knowledge sharing and exchanges, to create new collaboration and advance global health. So of course, our center hosts all the events of the Merieux Foundation. So we have 3 advanced courses: the advanced courses of vaccinology, ADVAC, created more than 20 years ago, a course on diagnostics, the advanced course on diagnostics. We just host the IMR course, the new one, the 2nd edition last week. And some of you were here, so it's good to have you again this week, Abdullah and Luc. And we host, of course, also Gabrielle, and we have also the Scientific Advisory Board a few weeks ago. But of course, our center is open to any organization in health. So on average, we host about 150 events per year. It's 5,000 to 6,000 people. And so there are international organizations such as the WHO, the Bill and Melinda Gates Foundation, but also UNICEF, INSERM, Pasteur Institute, and so on. And to conclude, I would say that we want to stay faithful to the hospitality tradition of the family when they created this center and when they gave it to the foundation. That is to create the best working environment for our guests so they can truly share knowledge, engage with each other, and be inspired by this beautiful nature. So I wish you a very pleasant stay with us during these 3 days and a very productive and fruitful meeting. Thank you so much. Enjoy your stay.
Thank you very much, Bénédicte, for this presentation of Les Pensières, this so beautiful place. It's a pleasure to be here now after a long time. So on behalf of Fondation Merieux, we are very happy to welcome you to this 11th. Sorry, I have. Can you put my slide, the slide? So yes, we are very happy to welcome you to this 11th International Gabriel meeting in this so beautiful place. And I would like to thank you all for joining us after a long period of time under the COVID-19 crisis, which made this meeting impossible to take place in December 2020, and after also in July 2021. We have to report this meeting in several places. A number of you were unable to attend today due to health restriction or visa issue, or for some countries, the borders are closed. But thanks to the new communication tools that we are developing here during the COVID epidemic, we are pleased also to have over 20 participants online as well during all the meeting. The majority of you have been working on SARS-CoV-2 since the beginning and have been strongly mobilized for SARS-CoV-2 diagnosis and also on research activities. And then we could not organize this meeting without having a day dedicated to these themes. And today we will have the full day dedicated to SARS-CoV-2. We will end the day with the Young Scientific Award, which is organized for the 5th edition and gives to 5 young researchers who have passed the first phase of selection the opportunity to present their research work. The 2 best presentations will be rewarded with a prize of 5,000 euros after being evaluated by a jury of 5 scientists present here today in this meeting. The 2 other days of this meeting will focus on the 3 themes developed within the network: acute respiratory infections, antimicrobial resistance, and tuberculosis. And this will be the opportunity to share the update on your research projects. We would like to thank the staff of Les Pensières, who is available to help you with anything you might need. I would like also to thank Marie-Charlotte for the logistic organization of this meeting, and also the Artcast for the technical organization. We would like also to thank bioMérieux for their financial support for the organization of this meeting. So we will you all the best for a productive and successful meeting and a very pleasant stay with us. And now it's my great pleasure to introduce you Marc, who is the medical and scientific director of Fondation Mérieux.
Thank you, Florence. So this is my turn to welcome you all for this first in-person Gabriel meeting since the onset of the SARS-CoV-2 pandemic. So as you know, the COVID crisis has really shaken up our lives. But from the lessons already learned, it has also created many new opportunities. First, it has put the spotlight back on infectious diseases and has underlined the need to strengthen research and innovation capacities in infectiology in both industrialized and low-resource countries in order to be better prepared against future pandemics. Second, it has highlighted the key role played by diagnostics, not only to track and trace infections, but also to design and assess appropriate control measures, in particular during the early stages of the pandemic. And third, it has shown how important it is to coordinate our efforts at the global scale to efficiently and rapidly tackle emerging and re-emerging pathogens. Thanks to this global cooperation, we've been able, for instance, to develop in record speed COVID-19 vaccine using new technological platforms, although this international effort needs to be pursued and ramped up in order to allow global access to these new solutions for the most vulnerable. In the context of the Gabriel network, I know that most of you have been at the forefront to set up COVID-19 diagnostic and research activities in their respective countries. And this will be clearly illustrated by many upcoming presentations during the next 3 days. It is noteworthy that in many instances, the swift implementation of COVID-19 diagnostics would not have been possible without year-long efforts to strengthen molecular diagnostic capacities, in particular through research implementation within the Gabrielle network well before the onset of the pandemic. Therefore, this crisis has demonstrated the added value and relevance of the Gabrielle as a sentinel network to tackle emerging pathogens, and we should take advantage of the COVID-19 momentum to further strengthen Gabrielle network capacities and visibility. Beyond COVID-19, Gabrielle members have been working on several other shared public health concerns, like tuberculosis, acute respiratory infection, and antimicrobial resistance, topics that will be addressed as well during the coming days. Besides discussing the action classically undertaken under the network umbrella, like training activities, project seed funding, support for young investigators, or implementation of multi-centric projects, I think that this meeting could be a great opportunity to further address and discuss ways to strengthen and communicate on the skills and expertise of the network, but in a bespoke fashion, that is according to the topics addressed. Indeed, while the network should build up cross-cutting expertises like quality assurance, biobanking, and more globally clinical research management, it should also try to gather and streamline a critical mass of skills on particular technological platforms like NGS, bioinformatics, syndromic diagnostics, or mass spectrometry-based microbiology. But these platforms should be differently prioritized from one topic to another. Customizing the structuration of the network and its roadmap according to disease indication could make Gabrielle even more attractive to its potential partner, and we are discussing with many of these currently, and could offer new opportunities for enhanced means and visibility. Finally, I have briefly presented during the previous Gabrielle webinar last January some new strategic guidelines of the Fondation Mérieux, which aim at strengthening synergies between activities implemented by its various departments in order to set more holistic programs integrating diagnostic and research capacity building, as well as community interventions. Such integrated program could really strengthen the impact of Fondation Mérieux action on the health and well-being of the most vulnerable, and in particular of mothers and children. This should be taken into account when contemplating the future of Gabrielle, for instance, by promoting stronger synergies with the RISAOLAB network, for instance, or by prioritizing projects with the strongest community impact. After these few words, so I look forward to listening to all your recent achievements and wish you a fruitful and lively discussions. Thank you. Florence?
Can I have the, the slide of housekeeping message, please? No? Yes, but it's not my Gabrielle network. So I would like to say some housekeeping messages. The meeting will be recorded and will be available on the Mérieux Foundation website. For the online participants, please turn off your video on your microphone during the presentation. For online speakers, turn on your camera during your presentation. To ask questions during the question and answer session, please raise your hand and the chairman will give you the floor. When called on to ask a question, also please turn on your camera And remember to introduce yourselves before you speak. We would like to keep close to our schedule. So thanks in advance to the speaker for not exceeding their presentation time. And thanks to the moderators for watching on the over this. So at the end of this session, we will have a group picture that will take place just before lunch today at noon for all of you, people that are present and online. So we will be here and all people online have to open their camera. And after the lunch, we are pleased to have the welcome address by Mr. Mérieux, the president of Fondation Mérieux. So now I will give you an update on the Gabriel meeting. And for those that didn't know well what is the Gabriel, it's the opportunity to know more about our objectives and our activities. And at the end, we will have a short discussion to know your feedback about the future activities. So can I have the slide now? The good, no, oh yes. Yeah. So Gabriel, it's an international network of research institutions located in low-income countries, and we have three main objectives: to improve laboratory and hospital-based surveillance and research for infectious disease with major public health impact. Another objective is to strengthen LMIC capacity to conduct clinical research, and also to foster assessment of innovative diagnostic tools to evaluate their performance. So here you have the map of the network. We are currently 20 members from around 16 countries around the world. Some members are linked to Ministry of Health, to universities or NGO. And as you can see, there are two colors. The red colors indicate the Rodolphe Mérieux laboratories. There is 9 Rodolphe Mérieux laboratories belonging to the network, and they have been supported since the beginning by Fondation Mérieux at the level of the infrastructure, and after we give a strong support to launch their activities, medical analysis activities or research activities. And in blue, we have 11 expert centers, which can help a lot for building capacity of Rodolphe Mérieux laboratory. And the objective of the networks to enhance synergy to address shared public health needs. So we are very happy, I am very happy to introduce you a new member into 2021, just joined in October. It's the Institut National de Recherche Biomédicale located in Goma, in Democratic Republic of Congo. It started activities in July 2020, and the main work was about the surveillance of emerging pathogens or re-emerging pathogens such as Ebola or COVID-19, and also they were well involved in COVID-19 testing in the country. So I didn't see Daniel. Well, can you please come and to introduce yourself with different, we have 2 slides. I think you will introduce your activities better than me. So please come.
Hi everyone. Merci beaucoup pour votre accueil. So I want to thank you for your warm welcome. I'm Dr. Daniel Mukadi, a medical virologist from National Institute of Biomedical Research, the National Public Health Laboratory of the Democratic Republic of Congo. And we are very happy to be here since, as you may know, our country have undergone 13 Ebola outbreaks, and we have one we still going on actually in the eastern part of the country. And for now, 5 years, I've been in charge of all Ebola outbreaks response laboratories. And as the aftermath of the collaboration, Professor Jean-Jacques Mouyembe, my boss, did receive from Mr. Mérieux a P3 lab that has been set up in Goma. Goma is located in the eastern part of DRC. And so we came from the very second longest Ebola outbreak in the world after Western Africa outbreak from 2013, 2016. And now we had 2 years of Ebola outbreaks with 13 laboratories deployed in 3 different provinces. And at the end of the outbreak, the pandemic COVID started. And so we were obliged to stay in the same country, in the same area, but now with a new lab, which was the BCL3 from Rodolphe Mérieux. And we started our activities with Ebola resilience at the end of last year. And then we introduced the surveillance and the testing of COVID-19. But later on, earlier this year in February, we had a new flare-up of Ebola in one of the cities in the eastern parts. And so the Rodolphe Mérieux lab served as the main lab for diagnostic and surveillance. And actually, we have one other outbreak with 8 confirmed cases so far, many deaths among the confirmed cases. And all samples have been confirmed within the Rodolphe Mérieux lab, and we have been able to sequence to find out that the sequence was related to Ebola survivors of the 10th Ebola outbreak. And this also one of the activity which is actually being performed within the Rodolphe Mérieux lab. And as we may see, INRB has a mission of surveillance, investigation, response to outbreaks. We did for Ebola, for dengue, for yellow fevers, measles, polio, etc. And we are also involved in biological diagnostics, and mostly also in transactional research. Just to know that during the biggest outbreak in DRC, we have been able to experiment the 4 Ebola therapeutic drugs, and which have been successfully concluded by the approval of Regeneron and MAB114, which was a molecule which was first tested in DRC with one of Ebola survivors. And this belongs to Professor Mouyembe works during those past years. And actually, we are treating patients with Regeneron and MAB114, and that works. And we still also have the pleasure to say that we have those molecules stored in Rodolphe Mérieux Colchien in Goma. And it's from Goma that we're organizing the Ebola response at the therapeutic site. We still have more than 500 strains Ebola in our P3 that we are working on and also sequencing. These are amongst the main achievements. And during these different outbreaks, we used to deploy laboratories and also to train laboratory staff. And we have shared our experience with our neighboring countries, such as Uganda, Rwanda, Congo Brazzaville, Burundi. They have come for several times in DRC to learn more about Ebola management. And we are also happy that is now a part of Rodolphe Mérieux lab in Goma. And we have agreed with the direction of laboratories that this should be, and it is now the regional lab. So it's serving now 6 different provinces of the Eastern DRC, For those who know, DRC is in Africa, is the second biggest country of Africa, and so our provinces are quite large, and we are very happy to receive that. And why we started, we have just received the P2 and P3 laboratories, and in 1 year, after 1 year of work, we have been able to set up a clinical diagnostic lab with chemistry, hematology, but also bacteriology, sequencing, and immunoserology. And we have also a functional cold chain, which allows us to start some other research activities. As you may see, just for more than 1 year and a half, we have been able to initiate and to work on those different studies with different partners. And I also to thank the Merieux Foundation, and especially Merieux Foundation in US with Corinne, as to be introduced to the infectious disease detection system, in which we have been able to map all laboratory of Eastern DRC, and we are now building a network of laboratory that will be, the headquarters will be the Rodolphe Merieux lab in Goma. I think this is the important part of my talks. Thank you.
Thank you, Dr. Mukadi. So now we will continue with the general presentation of the network. So we focus on shared public health needs, and especially on infectious disease that have a high public health impact. And these thematics that are being developed within the network have been selected by a bottom-up approach. So we focus on 4 main topics: acute respiratory infections, tuberculosis, antimicrobial resistance, and now more recently on emerging pathogens with SARS-CoV-2. So the studies that have been carried out focus from the benefits are done for the benefits of vulnerable populations, such as children, population living in remote areas, and also on refugees. And we have different types of studies: clinical research, operational research, for AMR surveillance with One Health approach, and also we perform surveillance with characterization, molecular characterization of the pathogens. So to strengthen the human capacity, we promote the training that are often linked to a research project. We also perform a lot of transfer of technology, for example, for the, by evaluate innovative diagnostic tests, especially for tuberculosis. And the quality assurance is also a key important in our activities, because we develop SOP, we perform audits for the during the research project. We put in place the good laboratory and clinical practices. So this is very important also to conduct a research project. So since a few years ago, we started to a new initiative to structure the network. Last year, we launched the second edition of a call for proposal, which aims to foster South-South collaborative research with the network. And these proposals are to focus on the thematics of the network. That means acute respiratory infection, TB, or AMR. The proposals are evaluated by external experts in the field. And the aim of this initiative is to get new preliminary data to better be prepared for external funding application. So last year, we selected 2 projects, one with the consortia with 3 countries, Cameroon, Brazil, and Madagascar, with the thematics of the evaluation of the impact of COVID-19 pandemic on the spread of antimicrobial resistance from wastewater. And you will have a presentation tomorrow on this topic. And the second consortium that has been selected, a consortium with a team from Bangladesh, Cameroon, and Lebanon, concerning the phenotypic and genotypic characterization of isoniazid-resistant strains of Mycobacterium tuberculosis. And you will have a presentation of the last day of this meeting. So, as I said before, one of mission of the network is to strengthen the human capacity and to perform knowledge sharing. So we have a lot of activities of training in the context of a research project. This allows to perform technological transfer, to train on clinical research management. And so far, we have organized more than 50 training sessions. We, in parallel, also, we organize some workshops. We organize in Bangladesh workshop in bioinformatics. We organized also in France a few years ago another workshop on bioinformatics. This year, we organize also a workshop on arboviruses diagnostic with our partner, the Institute of Medicine Tropical, located in University of Sao Paulo. This allowed to train 10 different participants from different states of Brazil. Due to the context of COVID-19, all the theoretical part was made remotely with recorded video lectures that are available in the website of Fondation Mérieux and also in the website of Zika Plan, because this workshop was organized thanks to the Zika Plan, which is a European consortium, and Fondation Mérieux was partner of this consortium. And there were also different practical sessions to learn more about the diagnostic, molecular and serological diagnostic for arbovirus. There were also some sessions to learn about the next generation sequencing and also viral culture. To support the young scientists, it's also very important. It's one of the mission of the Gabriel Network. We have a PhD scholarship program, and we have 4 ongoing PhD grants. 2 started in 2019. One PhD is from Mali, another one is located at the Institut Pasteur in Madagascar, in collaboration with the team in France. Last year, another PhD student was granted to work on SARS-CoV-2 characterization strains. And this year, we had a new PhD student from the Centre d'Infectiologie Charles Mérieux in Madagascar, who will work on HIV/AIDS infection in Madagascar to work more on genetic diversity and on antiviral resistance and co-infections. As I mentioned in the introduction, we will have today the 5th edition of the Young Scientist Award. And so we will have their presentation in the afternoon. And we have also, for knowledge sharing, we organize every 18 months the Gabriel International Meeting. And this year, due to the COVID-19, we organized also for the first time webinars. We had every month a webinar focusing on COVID-19. And so we had 4 speakers well involved in genomic surveillance on SARS-CoV-2. So 3 from Brazil, Marilda Sequeira from Fiocruz, Esther Sabino from University of Sao Paulo, Ana Vasconcelos from the laboratory, National Laboratory of Bioinformatics in Brazil, and also we had a talk with from Lily Ren from the Christophe Mérieux Laboratory in China. So I would like to also now to make a focus on the early response that we had all together for the COVID-19 crisis. Fondation Mérieux, we were well involved at the beginning to strengthen the capacity for the diagnostic of COVID-19. And many of you are major COVID-19 diagnostic center. In parallel, we also have different research works, and we have also developed a lot of research capacity building concerning COVID-19. For example, there is a multi-center study on nosocomial transmission, and tomorrow you will have a presentation on this study that has been done in different countries, as you know, and also in France, in different hospitals in France. And also since the beginning of the epidemic, we can observe the emergence of and spread of different variants of concerns across the world, and this led to different problems in terms of transmission, in terms of spread, and also they can affect the public health measures, can affect the diagnostic, the vaccines. So at Mérieux Foundation, we strengthen the capacity of some members to characterize these variants and to track as well. So we will have this afternoon a session dedicated on that. So at the beginning of the crisis, we set up early response. It was a very difficult time because at this time there was no commercial kits, there were no swabs, no reference materials, no guidelines. It was very difficult to organize the logistics because there were no airplanes, the borders were closed. In France, we were also in lockdown. So we tried to help us as soon as possible our partners by order all reagents necessary to perform the diagnostic. So we order kits for extraction, primer, probes, enzyme, positive controls, all consumables and equipment. And so we were allowed to support 13 countries from the network and also other Fondation Mérieux partners. So we provide a lot of support by developing standard operating procedures. As it was not possible to go in the countries, we organize a lot of video conference to respond to the questions of our partners. We analyze also and validate the first raw data obtained to be sure that everything is okay in terms of diagnostic, and we provide also a lot of recommendations from WHO. And I would like to mention that thanks to the previous studies that we had with our partners concerning the transfer of molecular techniques, it was very easy to transfer this capacity to perform the COVID-19 diagnostics. And this slide is just to show you for some members, it was not possible to indicate all of you because it's a huge work that has been done, but you can see what has been done in terms of testing activities of Rodolphe Mérieux Laboratory from April 2020 to August 2021. And you can see the number of samples analyzed in blue and the number of samples positive in red. And for example, you can see in Rio Branco and also in BT in Bangladesh, the huge amount of samples that has been tested. So you can see with these slides that the huge work that has been done by all of you. So this slide is just to show you the surveillance and research projects that are ongoing in the network concern nosocomial transmission. There are also a lot of serological studies to know more about the prevalence of the COVID-19. There are also a lot of works done on the characterization of SARS-CoV-2, molecular characterization, to perform surveillance in terms of emergence of variants. And this also is to give you an overview of some projects concerning the other topics on acute respiratory infection, TB, and AMR. And you will have during the meeting some presentation in detail. So I will not go in details today. So we have also some a lot of works, a lot of links with other networks. For example, Fondation Mérieux have other networks more dedicated to medical biology. For example, in Resaolab, it's a network located in West Africa. In Resamad, it's a network located in Madagascar. And we try to work also with these networks. And for example, for Resaolab, we opened the call for proposal this year to have also interaction between Gabriel and Resaolab. And there will be also in the future a new member of Resaolab which will join the network. He's working now on his application to join the network. We have also a project on AMR surveillance for the human part with Resamad. We have also a lot of interaction with Pasteur International Network. The Centre Pasteur of Cameroon is a member of the Gabriel Network and also of the Pasteur International Network. And we have a lot of projects with this center on TB, AMR, and on COVID-19. We have also a lot of collaboration with Institut Pasteur of Madagascar. We have also a lot of relationship and works together with Senegal, Institut Pasteur of Senegal, of Cambodia. We have also we also work with the Global Virus Network, which is aided by Christian Bréchot. We have applied altogether to NSF application to construct a network of network to be prepared, to be more prepared for next emerging pathogen. And so some of you are involved, for example, in Brazil, in Cameroon, in China. They are part also of this project. And now we are waiting for the result. We hope that we will succeed in this application. And Fondation Mérieux is also a member of the European consortium named EVA-G Global, which is a consortium of 25 partners. They are a strongly expertise in virology to collect, amplify, characterize, and distribute viruses and derived products to the scientific community. They cover a full range of human, animal, and plant viruses. And thanks to EVA-G, we were able at the beginning of the COVID-19 crisis to send the positive control for the diagnostic, because it was the only way for us to get these positive controls. And the consortium now aims to improve the control of emerging or re-emerging viruses. And also, we would like to strengthen the capacity building with EVA-G and to train laboratories from the between some Gabriel institution and also some institutions that have very high expertise in viral culture. And for example, if you have some very interesting samples that you like to characterize in terms of presence of virus to know more, we can mix twin with this institution. And I think it could be a very add value for the network to work with this consortium. So if you are interested to join, please let me know. So now I need your feedback on different points. So we will have the next meeting, Gabriel meeting in July 2023. For the moment, I don't know where we will organize it. The last meeting was in Lebanon, but we need to decide in which country of network. So if you want to co-organize the meeting, please let me know. Also, I think it will be interesting to continue to organize webinar, but in which topic, in which frequency. What do you think about the PhD scholarship program, about the Gabriel Research Call for Proposal? Is it something that you would like to continue to have this kind of opportunities? And also for the next year, we will have a new initiative. We will have a scholarship to promote training and exchanges between Gabriel members. For example, if you have a research project that you need some expertise, for example, in genomics, you can go in another labs of the network who have this expertise, and to be trained for some weeks on your own samples, on your own data for analysis, for example. So I would like to thank you all for your presence and for your contribution and your participation to this network. And so if you have any question, and if you have some comments concerning this proposition, please let me know now. We can discuss. The discussion is open. Thank you. Any comment? Any question? Yes.
Just want to congratulate you, Florence, and Foundation Merieux and the Gabriel, everyone. You've done so much in this time of COVID. And I'm just amazed to see all the things that have happened, and also the plans for making a South-South collaboration and exchanges for trainings. I think this will be very good for all the members. And,
yes, because the aim is to work as a network and to strengthen the collaboration between members. It's very important, and you can learn a lot each other from the experience of the others, because some members are very high expertise, for example, in diagnostic or in a specific pathogen. The others. So I think to exchange and to be in the labs for some weeks, you can learn a lot.
Exactly.
Yeah.
Thank you so much.
Yes, Graciela.
Hello, I'm Graciela Rusomando from Paraguay, South America. I want to express and to tell everybody that working in the network was very much helpful for Paraguayan people in the diagnostic of COVID, in the interpretation of the curves. And for us, I can say that it was very, very interesting to have the project of pneumonia in 2010, and to be working with all of you for more than 5-6 years in the project. And myself was very respectful in the country because we were very few people that understood very well the qPCR results and how to do the interpretation. In the whole country, there was not so much experts in the area of qPCR. And so I can say that it was very, very helpful to work in the pneumonia project for the interpretation and to be helpful in the country for COVID outbreak and pandemic. Thank you very much.
Okay, thank you, Graciela. Yes, Mark?
I would like to follow up on the few suggestions that I made during my introductory talk. Typically, the Gabriel network is presented as a kind of, I would say, artificially homogeneous entity, gathering many different players in all different countries. And I think that it's extremely important to really identify among the Gabriel members those who are more specialized in a particular topic, and try to determine, based on this analysis, what kind of expertise should be strengthened among the set of laboratories who are more specialized, for instance, in microbiology and AMR, on tuberculosis, on acute respiratory infection, or on emerging pathogens. If we can prioritize this, then in this case, we can progressively define a roadmap where we could focus typically on the lab who are more working, for instance, on emerging pathogens, and have the critical mass of skills working typically on bioinformatics or NGS. Then we can define actually a roadmap where we could identify those who would be the most eligible for strengthening their NGS capacities, possibly considering not only the use of NGS, for instance, to sequence COVID-19 variants, but considering NGS as a global tool to address typically, for instance, the strain variation in HIV-infected patients, or use of NGS in AMR. So, and since we have ongoing action, even within the Fondation Mérieux, for capacity building that involves some of you, either focusing on NGS capacities, but also on mass spectrometry microbiology, or on syndromic approaches. I think that then in this case, we could define different Gabriel networks.
But every year I ask to the Gabriel members to give me a feedback or on their main activities, on their techniques platform that are in place, to have a mapping of the strains of each other. And this is shared before the call for proposal between South-South collaboration. And so I think perhaps I need to reinforce this for you to have a more view of the current expertise in each member of the network, to highlight where are the skills, because all of you have some skills that they are not the same, but I think it's complementary.
But you,
Bill?
Just to go further on what Mark indicated, I think we should go beyond the lab, because the lab itself alone is incapable of conducting the research. So you need to look at a team of clinical researchers that's doing the clinical work. You need to look at, obviously, the lab, the pharmacy. You need to look at the data management, the ethics. It's this entire team that make a research team.
Yeah, sure.
So I think that part is essentially important.
Yeah, and most of the members are working closely with hospitals to and you are completely right that some skills to perform a research project are not only in the lab, and so we can include in the mapping the members that have also this expertise. It could be very helpful also to be trained on the conduction of a research project at the level of hospital, or how to analyze the data, how to collect the data, and so on. Yeah, you are completely right.
Going back here to the way we can leverage on Gabrielle to design communication tools that can advocate for what is done within Gabrielle and to create new opportunities for funding for Gabrielle members.
Sure.
We have to be very pragmatic. It's not necessarily, does not necessarily reflect working within a tight network, but it's an opportunity to showcase what we are doing and basically to give opportunities for those who are working on a particular area
to be connected,
and get new partnership. Sure. This actually happened this year. Daniel mentioned typically the connection with Gary Cobinger, but we have also tried to involve some Gabrielle member in other partnership opportunities.
Yes.
So I think that this should be streamlined. We should design really communication tools, highlighting what is done in each of the topic that you have mentioned.
Yes, one of role of Fondation Mérieux also is to identify some external collaboration that could be done with some members according to their expertise, and this can be also reinforced. Okay, I think we are on time, so if you have no more comments, we can move on the session on COVID-19. And now it's my great pleasure to introduce the two chairmen of this first session, Dr. Marianne Abdi-Fadel. She's the Dean of the Faculty of Pharmacy at St. Joseph's University at Beirut. And she also the head of the laboratory Rodolphe Mérieux in Lebanon, and the head of the Biochemistry and Molecular Therapeutic Laboratory at the School of Pharmacy, and Professor Papp, who is a professor of clinical medicine at the Weill Cornell Medical College in USA, and director of Les Centres Gesquio in Port-au-Prince in Haiti. So please, if you want to introduce our first speaker, Professor Lina.
Hello, everybody. We're going to start the second part of the first session. No, we're going to start the first session on COVID-19 by the keynote lecture, COVID-19 by 2022, Endgame or New Start, by Professor Bruno Lina from France, by Judeco. So I'm sure you all know Professor Lina, who has been playing a crucial role in the fight against COVID-19 from the beginning of the pandemic. Professor Bruno Lina is born in Lyon. He was graduated MD and PhD. He is professor of virology in the University of Lyon, head of the virology lab of the Hospice Civil de Lyon, Director at the French National Reference Center for Respiratory Viruses, including influenza, Director of the French National Reference Center for Enterovirus, and head of the VIRPA team at INSERM, CNRS-ENS, and Université de Lyon Research Center. He's currently a member of the French COVID-19 Scientific Council, member of the Scientific Committee of ANSES, and the expert of the French Ministry of Health, the Haute Autorité de Santé et l'Agence nationale de santé et du médicament. He has been temporary expert for the WHO and ECDC several times. He has published more than 400 peer-reviewed articles, several book chapters, and book on influenza and respiratory viruses. In addition, he is chair of the Global Influenza Initiative of the Global Influenza Hospital Surveillance Network and the Immuniser Lyon Scientific Committees. Professor Bruno Lina, the floor is yours.
Thank you. Thank you very much. Hope you can hear me well and see me as well. And thank you for a very kind introduction. So, and again, I want to thank Florence and Marc for the invitation to give this lecture. Actually, I really miss the Pensière site because I wish I could go there, but the timing is really too difficult to handle, and have everything done properly is difficult right now. But anyway, so I'm going to try to give you some insights on personal thoughts regarding the evolution of the SARS-CoV-2 epidemic, and it was a kind of, well, I would not say a joke, but still it was interesting just to challenge myself, letting me try to explain whether that's a big question right now. Are we going to reach a kind of end right now or not? And what are the signals we may have to see whether it's a kind of, well, I would not call that really an end game, but is it the end of the pandemic phase, or are we still going on these different pandemic waves? And we have to be very, cautious, because the experience we have regarding emergence of such a virus is well, basically we start from scratch. So we have no experience, and we have to be very humble about what are our speculation regarding the future. And to try to imagine what will be the future, we have to go back to what happened in the past, actually. And this is something that I dig out from a paper from Astrid Vabray, which was one of the very limited number of specialists we had on coronavirus in France before the pandemic. And actually, she wrote an interesting book chapter where she provided some insight into what happened in the past regarding the coronaviruses. And actually, she, and more than anybody else, knew that these viruses were has been responsible for pandemics in the past. And when you look at the 4 first lines, which are our basic seasonal coronaviruses that are responsible for mild disease like common cold and sometimes, but rarely, very severe disease in fragile patients, in immunocompromised. These viruses came from the wilderness. I mean, they have been pandemic viruses, and some of these pandemic occurred in the 19th century. And when you look at the third line, which is the OC43 beta coronavirus, it seems that it has been responsible for the pandemic of the 1890 year, where there was quite a significant pandemic that has been observed. And however, we forgot that this capacity of these viruses to become pandemic, because there has been 2 introductions that resulted in a fake pandemic or non-pandemic, which are the SARS-CoV in 2003 in Hong Kong mainly, and in Asia, but that reached the world, and the MERS-CoV, which is still ongoing, but there's no much cases. Although these viruses are responsible for very severe cases, and the path of these viruses to get into the humans were always the same. There's an origin, there's an intermediate host, and then there's a transmission to humans. And this is something that actually occurred. And when we have this path to humans that has been somehow rediscovered, we know that from the reservoir that is very much likely to be bats and there's a large number of coronavirus in the bats. And these virus, which is very similar amongst the alpha and the beta coronavirus, it's the same kind of viruses. Actually, if we want to get infection to humans, they have to go through an intermediate host. And this looks very much like the pandemic risk of the influenza viruses, where you have avian viruses that grow to an intermediate host and that may be adapted to humans as a consequence of this transfer to intermediate host. So we know that this may have happened in China, but so far we have not been able to decipher completely what is the actual way these viruses went into the humans. However, from the beginning, actually, we could see that this virus was, first of all, a coronavirus. That's what the electronic microscopy could show. The second thing is that it was replicating very well in the upper respiratory tract. That showed that it was fully adapted to humans. And when we look at the structure of the virus, it was very classical information that we had according to what we knew with the coronavirus, that there's about 30 spikes at the surface of the virus, which is an enveloped virus, with a genome which is really packed into the viral particle. And this glycoprotein, they have the capacity of bending at the surface of the membrane very easily, up to 140 degrees of bending. And this is also a protein that has some, which is metastable. And actually there has some change in the structure of the protein with, maybe you've heard about this RBD domain that can have a shape as an up or down. And when there's a down presentation, the likelihood of being able to bind to the receptor is decreased as compared to having an up conformation, which I will go back to that later on because it has impact in terms of transmissibility. So these viruses, there's a large number of viruses that have been observed and sequenced from the wilderness. And some of these viruses are able to jump to humans sometimes, but it's not always the same. And when we try to decipher what actually occurred in the beginning of the pandemic, this is the phylogenetic tree of the whole genome of the viruses that were detected in China, in the city of Wuhan. And actually you can see that all these viruses have exactly the same sequence. So there's an introduction, although we know now
sorry, we lost the connection with him, so he's going to come back.
We have a problem with connection with Professor Lina. He has a problem of connection. It's not from our side, it's from his side. So perhaps we can move to the next presentation, and we will come back with the Professor Lina presentation after the break. So can you introduce the next speaker, please?
So I'm honored to present Professor Jean-William Pape from IHE and to co-chair with him this session. As you all know, Professor Pape was also crucial, has played a crucial role in HIV and as well as COVID-19 from the beginning also. And Professor Pape is going to talk about the characteristics of the COVID-19 pandemic in Haiti.
Yeah.
Après, just have to click here to advance.
Avancer, c'est pas.
Avancer là et
D'accord.
reculer là.
Okay, perfect. Good morning, everybody. It's a privilege to be here and to present to you on the characteristics of the COVID-19 pandemic in Haiti. This is the outline that I'll be using. I'll present on the context of the pandemic, socioeconomic, political, environmental, and security issues, the contribution that our own institution has provided, the characteristic of the pandemic, its importance and severity during the 4 waves. We've had 4 waves, the lesson learned, and with some perspective and summary. This is the complex situations we've had in Haiti. We have a very divided country that ended up recently with the assassination of a president. This is something that had not occurred for 100 or more years. And nature has not been clement to Haiti. In addition to the 2010 earthquake, we've had a major one this year and a major hurricane as well. The understanding of the COVID pandemic that came on top of that is very poor, and I will explain why. Social distance is obviously not possible. Very few people are wearing masks. The acceptance of the COVID centers was not the case early on, but people accept to have them now. And we've had the presence of multiple variants. The 3rd wave was marked by the Gamma variant from Brazil that caused a lot of deaths. And then now we have both the Gamma and the Delta from India. The mortality is obviously much higher with those 2 variants. This is the national data on the 4 waves. As you can see, the peak of the 1st wave was in June. And we've had the 2nd wave that was kind of mild. The peak was in January, early in January. We had another peak in June in 2021. And since August, we are starting our 4th wave. This is the map of Haiti. The darker areas shows the density of the pandemic. And as you can see, the West Department, which is where the capital is located, has the majority of the cases, 48% of the deaths. This is also where 40% of the population lives. This is the curve that shows the increasing cases of COVID in red. We should agree on one thing that I think is important. Confirmed cases does not really tell you about the pandemic for 2 reasons. Number one, the majority of people are asymptomatic.
and usually they don't get tested. And secondly, depend on the capacity of the country on the number of people that they can evaluate. However, hospitalizations and deaths, this is really what's telling you of the severity of the pandemic. The role that we've played, I was asked by the president to serve as the co-president of the National Commission. We focus on saving lives. Diagnostically, the laboratory Rodolphe Mérieux played a key role because we were the only lab with the national lab that was able to do PCR tests on multiple platforms. We also had 2 care centers. We did a lot of training of medical staff. We participated in the epidemiologic surveillance in our own patients. The 2,000 patients that come to our center daily are evaluated for COVID on a daily basis. But we also took part in the evaluation of people at 2 of the key crosses between the Dominican Republic and Haiti. We evaluated the antibody response, we searched for variants, and we are very much part of the vaccine promotion and delivery. The national plan, this is what we had focused on, save as many lives as possible, and also on behavioral change. We had a crisis center with 4 clusters, all in the same place, a center that took care of care centers, the one in charge of communication and behavioral change, the one that ordered goods and logistics of distribution, and the one that was linked to epidemic surveillance, laboratories, and port of entry. The fact that they were all at the same place was very useful because we were able, for instance, if a center needed one particular reagent or one particular medication, immediately to make sure that they got it. We were quickly able to increase the COVID-dedicated beds in the country to the point that only one hospital during a short 2-day period was overwhelmed. All the other hospitals had enough bed at all times. This is the surveillance part that we were involved with our own sites and also for travelers and at the 2 border crossing with the Dominican Republic. This is our own data, and you can see the 4 waves, similarly to what you see in the national data. Curiously, our data precede the national data by about 1 week. So we could tell the Minister of Health that you're going to have a new wave at a very short period of time. This is the data from the border crossing with the Dominican Republic. And as you can see, those are all PCR confirmed cases, and there are 200,000 people who cross the border on a daily basis. Now, on top, you see the map of the island of Hispaniola, the Dominican Republic and Haiti, and we're able to document where those people came from in the Dominican Republic and where they went when they came to Haiti. This is the part that we did a lot of training. We produced 2 booklets, a booklet for people who are cared for at home, those who are cared for in the hospital. We also had an online training course, and those are the 2 centers that were treating COVID patients. This is the Rodolphe Mérieux lab that with 2 BSL-2 and 1 BSL-3 that really was essential for the diagnostic cases. Now, this is where we failed completely. Although we had a huge campaign that involved millions of people who were informed, leaders at all levels, people were informed, as you will see, but behavioral change did not occur, and I'll show you why. Unfortunately, the measures taken by the government to close the airport, close schools, etc., had a bad effect on the health programs. As you can see, less women came in for delivery, and of course, it led to an increased maternal mortality. We had decreased immunization in children and increases cases of diphtheria and even malaria. Although we are testing less cases, we were able to see more cases of malaria. Now, the second wave was very quiet. There were very few hospitalizations, very few deaths, to the point that there was even a carnival in the country in the Northwest, in Port-de-Paix. And that's when also COVID testing was required for travelers, and therefore it increased the capacity of various laboratories. This is very interesting. Those are the IgG prevalence tests that we did on a number of populations. And what I'd like to put your attention to the group of people that mingle with a lot of others turn out to have a large percentage with antibody response that were positive. But also what's significant, look at the private sector, only 13% were positive. On the other hand, our patients, a very high positivity rate, similar to those who are PCR positive. And also some PCR patients, 26% were positive. And I think this will have an impact on what we are seeing really in real life. The third wave, on the other hand, was very infectious. When we had one person infected, the entire household was infected. The disease was much more severe, requiring a lot of acute care. And we had, for the first time, 12 transfers of very sick patients outside of the country. The mortality was much higher, but we had, people, older people with comorbidity, particularly diabetes, who end up dying. But people who died mostly were people in the middle class and people in the upper class. Our patients, because we see very few patients, very poor patients, those were not dying, to the point that our 2 hospitals remain closed. This is really amazing. If they were open, if they were sick, we would open the hospital. We documented that people got infected, but they didn't get sick enough to be admitted to hospitals. Now, what about the lineage and circulating viruses in Haiti? You can see early on in the first round in May, we had mostly the B virus, B1, 59%, but already in January of 2021, we started having P1, the Gamma variant, that increased to 77% and 90%, was totally dominant. And then in June, we started having Delta that became more and more prevalent. And I'll show you, this is the most recent results we have. It's mostly a Delta right now, 68%. And I think that it's going to dominate completely what we are seeing. Now, there were many studies done to evaluate whether the population knew about the virus. And as you can see, 98 to 99% are aware of the pandemic. They are also aware that it is fatal. So they are well informed. Now, when they ask them if the virus is present in Haiti, you'll see the majority will say no. And this year, more people said the virus is not in Haiti. And the reason is that the majority do not know anybody around them with the disease. So that shows that the severity of the disease has been very, very mild. Now, when they ask them whether you would be willing to take a vaccine, you see that Haiti is at the bottom of the scale. Very few % of people are willing to take the vaccine. Now, the national campaign started on July 17. We started 1 month earlier at Guesquio, and we are part of the campaign. Right now, there are 128 centers, about 100,000 people have been vaccinated, 14% by our own center. But I must tell you that a lot of people in the middle and upper class have been vaccinated. In fact, I encourage them to get the vaccine when we are not getting them. It was given free in the US. And then whenever I was traveling, I saw a bunch of people go in thanking me that I had encouraged them. So they don't count in those numbers. Now, this is very interesting. You see all 4 waves. You look at the number of cases, but look at the number of cases who died. The first wave, we had 233. The second wave, very few people, only 17, for a total of 250 after the second wave.
But the third wave linked to gamma, we had 287, twice. So we had more cases during that third wave than during the first two waves. And now we have 76 cases so far with Delta. But overall, the mortality rate is fairly low. Now, even more interesting, look at comparative deaths. In green, you'll see people who've had very mild pandemic. Look at the number of deaths per 1 million. Benin, 12. Democratic Republic of Congo, 11. Look at Haiti, 58. So this is asking whether there would be a genetic component to this, because many of the slaves who came to Haiti came from the Republic of Benin and the Democratic Republic of Congo. On the other hand, look at South Africa with a lot of cases. So I think that, this is something that we should look at, even our network, to see where we fit in terms of mortality. Now, why is the pandemic more severe in some countries and populations? Clearly, age plays a major role. In the slum, right across where we are, very few people are above the age of 65. This is national data. In the slum, it's only 2% of people who are older than 65. The other thing also is herd phenomenon. What if when you live in a large slum, you are exposed constantly to viruses? Could they be asking, could this be performing as a booster, constant booster virus that you get in the community? And in that case, you get infected, but not necessarily getting sick, because the infectious dose is what makes you sick in any infectious disease. So if the dose is very limited because you're under the sun, that could play a role as well. What about cross immunity? We found that there was a coronavirus from animals that we were able to identify in specimen that we had saved from children who had Zika. So is it possible that they were exposed to previous coronavirus? That's also a possibility. And the genetic factors, perhaps where that could play a role, is in the immunologic reaction to the virus. We know that what kills people is not the virus itself, it's how your body reacts to it. That's why steroids play a major role. So we know there have been data to show that there is a link with the immunological response and some genetic factors. So perhaps this is also part of the reason why people don't die so much in some countries. Now, the lesson learned is that the pandemic is concentrated in crowded and urban centers. The Dominican Republic-Haiti border has been a main source of transmission. The Dominican Republic has had a very bad pandemic. It's been mild in Haiti, with mortality mostly in the older age group and also in people with higher socioeconomic status. The poor people don't get sick. That's probably why they don't wear masks and do not see the need for vaccine. Some of those measures had a negative impact on health programs. So that's why I had urged the president to reopen the factories, because this is the second source of income in the country. I was much criticized for that, but later on, people agreed that this is what should be done. Controversies about the pandemic, there have been a negative role of social media, but also the negative role in the medical community. I think this is where it started, because we've had many people indicating that such medicine work, and we find that at the end of the day, it didn't work. So when you have confusion in the medical community, it's created an amazing amount of confusion in the lay population. And finally, in summary, that pandemic has affected Haiti at a time of tremendous political, social, and environmental turmoil. Based on projections from Cornell and Oxford, I had predicted that there would be 300,000 deaths. So fortunately, this did not happen. I was much criticized for the bad prediction that I had in the country. The pandemic in Haiti has been much more severe in other Caribbean countries. The fourth wave now, we don't know what's going to do, but I can predict that it's probably not going to be as bad, and most likely people will resist, the poor people, the majority, will resist the same way they resisted to the Gamma, and perhaps the Gamma is protecting them against the Delta. It's urgent to promote vaccination, but one could wonder, should vaccination be promoted in people who've had antibodies and who've been constantly submerged by booster from others? So I think this is a question that we should ask and should try to find answers, because clearly pharmaceutical companies will want us to vaccinate the world, but will that be necessary? So I'll leave you with this question. Thank you very much.
Thank you, Professor Pape, for this very interesting talk. The talk is open for discussion.
Bill, I was wondering how generalizable are these observations, in particular regarding this rather much lower incidence of a severe case among the poorest. Does it fit, for instance, with the situation in Brazil? And or if you consider, for instance, the impact of age versus what you call the slum effect, and that could be linked with either infectious doses or cross-reactive immunity, then in this case, would you consider that even people who are at risk in slums and are older would be better protected than those with similar ages and susceptibilities among middle or upper class communities?
Okay, that's a very important question. We are trying to answer that because you see, presently, the first cause of mortality in Haiti is cardiovascular disease. HIV/AIDS, which used to be the first cause for a long time, is now the 7th cause of death. Cardiovascular disease represents 28% of mortality. So we have a large cohort of 3,000 people with hypertension. That's really the leading cause of cardiovascular disease in Haiti that we are following. So we are looking at those people, matching them, because all our patients are from the slums. So they are very poor people. We see 2,000 of them on a daily basis. And for some reasons, they don't die of COVID. So we should really match them with population with upper class and middle class to see whether that makes the difference. But if I had to pick, I would say that age is the number one factor. Clearly, we see that people who are younger are less affected, but occasionally we've seen some very young people in their 20s and apparently in very good shape physically who end up dying of COVID.
Thank you. Professor
But I think this is perhaps an opportunity for our own network, because there are slums in many other countries in this network to look at what I think is a key question, because if indeed this is correct, that would advocate for non-vaccine administration for people in those populations.
Thank you, Professor Pape. Professor Kadji.
Yeah, thank you so much, Bill. And also to answer some of the points that was raised by Mark. I mean, what you saw over here is exactly what we are seeing in Bangladesh. It's in the slum, our seroprevalence is high, but very little death. They don't even want to be tested because they're negative. They have only cold and things like that, and did not believe that there was anything called a COVID pandemic. But some other questions. I think diabetes has been found to be a risk factor, and it's slums don't have over 65 people. They go away because they cannot do labor. And the other thing is that, age is a factor in the beginning of the pandemic in Bangladesh. But lately, when we had the Delta variant now, the age has gone down. younger people are dying. But in the beginning, it was diabetes, obesity, heart, other chronic diseases that. I also want to talk about vaccines. I'm a great believer in vaccines, and I would think that, what you get, the seroprevalence levels by natural immunity is not enough. You need to have vaccination to get herd immunity. So in Bangladesh, we are very vaccine friendly, and we have a great belief in vaccines, and people are coming up readily, no hesitancy at all. And I would think that something has to be promoted in Haiti too, for meeting the pandemic and controlling the disease. But we have so many similarities. This is a great instance where we can do South-South collaboration.
Well, I think your points are very well taken. The issue is that it's not that people don't believe in vaccine, because when we had the cholera epidemic, this was the first cholera epidemic in Haiti that ever existed. People poured in our place to get vaccinated. We vaccinated the slum 2 doses in no time, and we're able to stop the epidemic in the slum. If there were an AIDS vaccine, I guarantee you, people will come. So poor people are pragmatic. When they don't see people dying around them, they have other things in mind that they need to deal with. They have their own food to provide to the family and other major needs. So vaccine is the last concern at that time. So it's not that they are against it, but how can you promote vaccine if they don't have deaths around them? And as you see, 85% said they don't know anybody with COVID. And another question, 95% said they don't know anybody who died of COVID. So it's a different setting. And perhaps what we need to be looked at is not only factors taking into account age, but the variants as well, because we know variants in both Bangladesh and Haiti. The Gamma has been important in Haiti, important in South America, because it came from Brazil. And the Delta has been important at your place. And
one Gamma in Bangladesh. But I think the cross-reactivity is something that we need to talk about. But before March 20, we did not, until March 20, there was no antibodies. I've done it myself, no antibodies to SARS-CoV-2, and also no cross-reactive antibodies. So there's some other things that we should think about doing.
Thank you. We have time for just one last question from Anna Teresa, Dr. Anna Teresa online.
Please, Anna, if you can ask your question, open your camera.
Bonjour, good morning, everybody. It's a very interesting study, and in Brazil is the opposite side from the Haiti and probably from Bangladesh, because most of we have a high mortality in the slum person that live in the slums, and also is in the complete. We have a 600 people dying in Brazil for COVID. So here, everyone know one person that one or more than one person that died from COVID. So this is a population that, and we had the same variant, that's the Gamma variant. So I think this could be a very interesting study to compare the population from different countries, from Brazil, Haiti, Bangladesh, and so on, and to see the impact and the genetic importance of that. I think this to integrate the virus and the genetics of the population is a very interesting thing to do. And we have some study for different groups in Brazil that can compare these studies. So thank you very much.
Thank you, Professor Pape.
Thank you very much, Professor Pape. Now, I think it's time to have a very short break, because we will have the presentation of Professor Lina at 11 sharp. So please come in the room before 11. Thank you very much.
So we're going to start. Professeur Lina, vous êtes avec nous? Vous
Yes.
nous entendez?
Oui, oui, je vous entends très bien. Je vous entends très bien.
So
Je suis
we're going
navré,
to start.
Mm.
Sorry for the inconvenience. So we're back. The floor is yours once again, Professor Lina.
Okay, thank you. I don't know where, if I can you see my screen? Okay, but I can't have the is it on is it a diaporama mode, or is just, you know, you have the slides at the side?
Bruno, no, it's not diaporama mode. We see the slide in the left side.
Yeah, hold a second. I don't know why I can't do it. Anyway, what we can do maybe is just do it like that.
Yes, we can see very well your slides, so it's not a problem.
Yeah, sorry about that. So I don't know where it stopped, but obviously I had a problem with my Wi-Fi connection here. So I told you, maybe you could hear that there has been introduction in the past of the coronavirus, and that is something that we just rediscovered. I also explained to you the way that these viruses are going into human, which means that they need an intermediate host, and this intermediate host has not been found in China so far. That these viruses, when it jumped into humans, it has been already immediately fully adapted, and we rediscovered some of the biologic features of this virus, and especially the features of the spike, and I will go on that again. And I think that is more or less when I just lost my connection, is that when I explained to you that the reservoir of coronaviruses we have in the wilderness is huge, especially in the bats, and there are some already existing intermediate hosts for which we may be wise to do some kind of surveillance. And when we do the surveillance according to what has been detected in China, what we did see actually is that the viruses that emerged and that were detected and sequenced from the first cases were almost all identical. And there were some very close similarities in terms of sequence with viruses that were detected in bats, either in bats that were sampled in 2013 or in bats that were sampled in 2019 in places that were not really close to the Hubei region where this virus emerged, but however, these viruses were very similar. And what we also detected is that these viruses were circulating in pangolin, but although the viruses in the pangolin were pretty close in terms of sequence as compared to the human viruses, but they were most likely not those that were involved in the transmission from the bats to the human, because the sequence that we had from the virus in the pangolin were somehow a little bit more different than the sequence that we had in humans. It's impossible for the virus to go from very close to humans to far from humans and then back close to humans. So there's an evolution that is going on there, and we haven't been found the intermediate host. And one of the things that tells us that there has been an intermediate host and that this virus has been really replicating in this intermediate host is that there has been some changes in the sequence of the virus, and especially in the sequence of the region coding for the S protein, because in this S protein, as compared to what we have seen in the bats, there's been an addition of polybasic cleavage site close to the furin site, which is an important region of the protein where the two subcomponents of the S protein, S1 and S2, has to undergo cleavage to allow fusion. And this introduction of a basic amino acid in this region is something that we see sometime when the virus jumps to an intermediate host from the bat reservoir. So this is also something that tells us that there has been some kind of adaptation in an intermediate host. And when you look at what actually is known in terms of dissemination of coronaviruses in different species, actually, when you look at the structure of the spike, and you look at several determinants where there could be some specific determinants that are related to specific species, what we see is that there's actually three major domains that could be analyzed. The receptor binding domain, which is a domain that is supposed to interact with the receptor at the surface of the cell. And you can see that in these positions, there has been described some specific substitution or modification or sequences that are fully adapted to different animals. It could be cats, it could be rodents, it could be ferrets, it could be minks, it could be humans. And it could be large animals like lions, for example. And there are some other regions where the virus can undergo a certain number of changes, which is the N-terminal domain. And the N-terminal domain is the region that is supposed to interact with the immune response. And a lot of neutralizing antibodies target that region. And we know that, for example, there's been changes in a specific region with viruses that have been detected in cats, in minks and in humans in this specific region. And there's another one which is more the core of the protein, and that is where is the polycleavage, the furin cleavage site, but there are also some substitution that could be driven by the selection through replication in different species. So this is interesting knowledge, because it means, first of all, that a lot of animals could be infected with these coronaviruses. And the second thing is that these animals could be infected either from the bats or from humans. And this kind of reverse infection is something that we really need to monitor on the long term, because it may induce some changes in the regions where the immune response is supposed to be very important. So when you go back to the emergence of that virus, the very first viruses were detected in 2019, as it was said, and the very early sequence of the viruses that we had were very close one to each other, which means that there was a kind of clonal expansion from a limited number of different viruses, and all the viruses we could detect worldwide were very similar. But when you look at the first step of evolution of that virus, actually the first one was a substitution in 614. And this actually changed a little bit the shape of the S protein, because by the introduction of this mutation, which is here in the middle of the protein, what actually does is that it changes a little bit the conformation of the glycoprotein, the trimeric protein there, with a kind of, you may imagine that this spike protein is a blossom, and this blossom was very packed when it emerged from the bat. But then with this substitution, the 614G, then the blossom started to open itself. And by opening itself, like it is depicted here, actually it increases the capacity to bind to the receptor binding site, which is the ACU2 receptor. So this very first evolution that was detected in Europe in February actually increased the capacity of the virus to be inserted into humans. So it shows also that this virus had to go undergo some adaptation to the humans to enhance its capacity to be transmitted. And by this, what happens actually is that we had to make a classification between the different viruses that were detected, and this is a classification that was proposed by March, and that is Gizzard which proposed that. We had 3 different lineages that were identified. There was the S lineages that was the largest lineages, which had actually a substitution in one of the open reading frame, which is one of the reading frame which is involved in the control with the immune response, especially the innate response. There was another mutation which is called the group S. There's another which was more visible from the beginning, which was the V group, which was observed in the non-structural protein 3, and this is a limited number of viruses. And then there was this emergence of the G group, which was related to the 614G mutation. And when you look at that time, what was circulating in the world, actually the world was already facing the pandemic, which was at the very beginning of the circulation of the virus, but the virus was everywhere. And like I said, the most important number of cases were detected in Europe, and that is where this substitution was detected first. And very rapidly, like I told you, this virus had an advantage of having this G mutation at 614, which means that the number of viruses that were detected with this specific molecular threat was really expanding. And when you look at the little panel inside here, you could see that the proportion of sequences that were deposited into the Gizzard database was progressively increasing with the G protein. And this is really something that was the hallmark of the beginning of the pandemic. So this was this virus that was responsible for the first wave. Be careful with the size here, because you will see that in the subsequent waves, the size of the is much bigger than that. But what we do see is that the first country that was hit in Europe was Italy, and then all the other ones started more or less at the same time. And then there was also Russia and the United States that were hit by this first wave. And the first wave was supposed to end sometime in June. And remember, some people thought that it was over. But then we had the second wave. And again, look at the size. And this is not because of the intensity, but it was of the diagnostic capacity that you had that difference. But the second wave occurred during the autumn of the northern hemisphere, and that was very, this wave was very big and very sharp, and it was observed in all countries almost at the same time. And then we had the third wave, and this is the second wave. And this is, no, sorry. So this is the first wave, this is the second wave, and we had the third wave. The third wave here was seen, there was some delay, sometime with the second wave in some countries, but the third wave was seen mostly in Europe and all over the world during spring 2020 and 2021, sorry. And also, again, it hit a lot of different countries. And then we had the fourth wave, and the fourth wave is the one that we did this summer. And the fourth wave was actually the consequence of the emergence of the Delta variant. And I will come back to that later on. And now, actually, there are two options in two different countries, group of countries. In one group of country, you have a decreasing trend of the number of cases, whereas in others, you have exactly at the same time, which is today, an increasing trend of the number of cases. And when you look at that, for these countries, it's obvious that there will be some kind of fifth wave, but it's actually maybe the fourth wave that has been delayed. Not only, and in some other, it seems that there's a kind of plateau or a decrease in the number of viruses that are detected. So what is going on? And actually, what is going on is that there's a discrepancy between Northern and Southern hemisphere, and there's a discrepancy between, at least when we look on Europe, between Eastern Europe and Western Europe. And this could be explained very clearly at the level of Europe by the fact that there's a kind of east-west gradient and maybe north-south gradient, because if this country would be colored, it would be in very black. For the UK, it's just because it's not anymore in Europe, like you said, but there's a gradual introduction of the virus going westwards from the countries that were hit first in Eastern Europe. And it is, again, probably related to the fact that we have a virus that has a high level of transmission. And in some of these countries, the level of vaccination is too low to allow the control of the virus through the herd immunity. Let's go back to the different sequence. And again, when look at what I told you, this G group is representing now more than 99% of the virus. We still detect some S and V and L genogroup, but it's very limited, and these are viruses that doesn't exist anymore. So we have this G group, and within the G group, there's at least 4 different subgroups that have been identified: the alpha, the beta, the gamma, and the delta. And you're perfectly aware of these viruses. What has actually changed? First of all, there's a trend of evolution in terms of mutation in the spike protein. When you look at the early days, I mean, the emergence of the alpha virus, which was the middle of and the end of the second wave, is just before the third wave. Actually, the third wave was a result of the alpha. And before the alpha, there was a limited number of mutations that was observed. But then there was a large number of substitutions that were observed in the spike protein. And when you look at the diversity of the mutation you can detect right now in the spike protein, it's huge. It doesn't mean that all these mutations are all together in the same protein, but this protein can evolve, and some only of these substitution can be selected positively and induce a kind of convergent evolution where actually they tend to be stabilized because they increase the fitness and some of the capacity of the virus. And when you look, for example, the level of excretion of the virus and the rapidity of excretion of the virus, when you compare the alpha virus that was sometime thought as the hallmark of the better fit virus, actually the delta virus, in terms of CT value, there's a lower CT value in the individuals infected with delta, which means that the virus replicates faster, and there's the the quantity of virus we detect in the nasal, in the nasopharyngeal swabs is higher, and the duration of the excretion of the delta seems to be a little bit longer, and again at a lower CT value, which means with more viruses as compared to the delta. So this virus is clearly better than the alpha, and as a result of that, actually we have that when you look at the trend of circulation of the different viruses around the world, actually the gray zone is the historical viruses, and you can see that they are more or less disappeared. And then you have the different variants of concern, which are listed here. The red one is the alpha, and the alpha was really predominant. It tended to co-circulate a little bit with the other, which was the beta and the gamma virus. But when the delta emerged from India, actually it crushed everything down. It displaced completely the other variants. And when you look at the distribution of the virus we have all over the world now, it's clear that the delta has taken over. And actually, when you look at the properties of the delta as compared to the other viruses, one of the very important features is that when you look at the respective R nodes of these different viruses, should we be in a naive population, the guess we have about the R node of the delta, which is the B1617.2, actually would be around 6. Which means that when you look at the historical viruses where the R node was supposed to be around 3, between 2 and 3, and the R node of the alpha was just in between around 4.5. So this virus has clearly an enhanced capacity of transmission, and this is due to the fact that, and I will go back to that, some of the substitution that occurred in this protein in the delta variant tend to have this S protein being more stable and having the receptor binding site in a shape that will be the up position. Maybe you know that there's 2 positions of the RBS in the protein. It could be either up or down. If it's down, it's less likely to bind to the ACE2, and if it's up, it's more likely to bind to the ACE2. And by the introduction of 2 substitutions that are key in this virus, actually, the tendency is to remain with the RBS up, which increases the capacity of being stable for the S, and as a consequence to bind more closely to the ACE2 receptor. So we can explain why this virus is more transmissible. It's because it's more stable, and the capacity of the about 30 glycoprotein that are at the surface of the virus to bind to the ACE2 is better as compared to what we did see with the regular viruses, the historical viruses, and with all the other variants, I mean, the alpha, the beta, and the gamma. And within the different subgroups of delta, there's been some molecular classification within the subgroups, and you have to remember what I said. It's a molecular classification because as of today, none of these different AY lineages, have any additional capacity as compared to the regular viruses. It's only molecular typing which is there. And when you look at the dissemination of the delta is taking over everywhere. So it's going to be the one single virus that will circulate, but will that virus remain only with the delta features, or will we select some of the molecular variants? It's very likely there would be some increasing in the AY4, and I will talk about the AY4.2 a little bit later. But again, all these viruses are very similar. One of the big questions we have regarding these variants is what about the immune response? Are we still protected with the vaccine we have so far. So to understand that, what has been done is some kind of antigenic cartography. For those that have knowledge in influenza, that is something which is very similar to what we do with the influenza viruses. And this antigenic cartography tells us what is the level of cross protection you have when you're infected with, when you're immune against one virus and you're exposed to another one. And the further the viruses are on this map, the less likely the cross protection is going to be sustained. But in terms of cartography within the SARS-CoV-2 variants, actually, as of today, there's no significant variant that escaped from the immunity acquired through the vaccination or through the infection. And actually, what we do now is based on the cartography of these different viruses. This is the Wuhan strain, which has been the vaccine strain. This is the alpha strain. This is the first mutant, the 614G. And here you have the beta and, sorry, the gamma and the beta viruses. And this is what we call the antibody coverage, the antibody landscape you have when you are vaccinated with the vaccine strain. And what this figures tells you is that when you look at the average antibody titers in terms of neutralizing antibody titers, you have when you have been vaccinated against the different variants that are circulating, in all cases, this vaccine is protecting against all the circulating strains. And when you look at immunity induced by infection, which is not exactly the same as immunization, what you could see is that in terms of protection, when you're immunized by infection, the quality of the immunity you have is not as good as the one you have with the vaccination. It means that the vaccination is immunizing better than the infection. And the second thing which is important to understand is that when you are infected with, for example, a beta virus, actually the immunity you have against the alpha is not as good as the one you have against the vaccine, which means that in terms of cross protection, an immunity with the original viruses or with the original vaccine is better than the one you would have if you're infected with the beta or the gamma virus. And this is very well seen when you look at the antibody coverage that you have against the different viruses which are on the map here. And you could see this is the coverage you have if you are vaccinated with the Wuhan strain. This is the coverage you have if you are infected with the alpha strain. And this is the coverage you have if you're infected with the beta strain. So it's better to be vaccinated in all cases. And when you look at the position of the Delta on this antigenic map, it is located here. So it's opposite to the alpha, to the beta and the gamma, and it's very close to the alpha and the original strain, which means again that as of today, we have no reason to change the content of the vaccine. The vaccine is really covering all the different viruses that are circulating. And what about two, which makes a lot of going on? Again, when you look at the two major mutations that have been detected in the AY 4.2, it's the A22V here and the Y145H on the receptor on the N-terminal domain. This mutation has been detected in a significant number of other viruses, and it has not been shown to be really reducing the capacity of antibody binding in terms of protection. So the cross protection we have with the vaccine remains very good, as it was for the alpha, because the alpha had that kind of substitution. Regarding the 222 V actually tend to be stabilizing the virus, but not as much as what we did see in the Delta originally. So actually, these two mutations have absolutely no impact in terms of transmissibility and fitness of the virus. So, and I will end up with some of the questions we have. So, will the vaccine be enough to control? Actually, yes and no. Yes, because we know that the vaccine like we have right now is the best vaccine we could do, and there's no need to change the vaccine composition. Should we have a look at the optimized vaccination scheme? Actually, yes, that's the point. I mean, we don't know how many doses are required to have a long-term immunity, and we don't know if we should not mix the different vaccine, you know, the adenovirus vaccine and the mRNA vaccine to have a better immunization. We recently published a paper showing that combining two vaccines could be good. How will the epidemic evolve? Is there a new variant? I mean, the new variant, as of today, there are no new variants. And the Delta is stabilized and all the sublineages are just behaving like the Delta. Will this virus switch and be sustainable? Clearly, it will be sustainable, yes, and it will clearly switch to a seasonal virus. When will that occur? Nobody knows, but maybe it will be directly related to the immunity we will have in the global population. So what about the non-pharmaceutical interventions? Well, actually, as I think that today we have to keep using these non-pharmaceutical intervention, maybe until the end of the winter. And this will be protective against the SARS-CoV-2 and the other respiratory viruses that re-emerge. So we have to keep there. Are we going to need these in the future? That will be based on the habits that we will take after this pandemic. But we can think that maybe if the virus is going to become an epidemic virus, like the seasonal flu, and there will be seasonal SARS-CoV-2, then maybe we will have to take out of these masks and use them in the future to prevent transmission. So it's back to my first table. I think that now we have to add this new group of coronaviruses, the SARS-CoV-2. We know it comes from the bat. We don't know yet what is the intermediate host. It was introduced in 2019, and it's very likely that it will become ubiquitous, seasonal. I don't know whether it's going to be 21 or it will be 22. And I will end that with that. Thank you very much.
Thank you very much, Professor Lina, for this amazing talk. The session is open to questions.
Very nice presentation. I am from South America, from Paraguay, and next to me is Brazil, sitting here. We complain a little bit with you because because Gamma was mainly in South America.
Yep.
During 2020, the 614G was the most causative of the cases in our countries. Yes, we didn't have too much Delta, Alpha or Beta. So we had a pandemic, an epidemic in each country with CT values at the diagnostic test with 24, 25, a little bit around 20 and up. Yes, not 20 and less. When Gamma was introduced, or P1 or Manaus strain, or whatever you want to call it, it started in Brazil. It caused a big spread in our countries. And this variant was high transmissible. It produced high viral loads detected by the qPCR. Most people by May, June, July were under 20. Those positive cases were CT values under 20, more than 50% of the cases. So we had the worst pandemic in this year, 2021, most of our countries, many deaths, and it is due to the Gamma variant. South America, I'm talking. So we consider that Delta will not be a big problem for us because we have in Paraguay, we detected Delta, also Brazil, in May, June of this year. And we have since June, Delta, and there were no more big problems in the system. We are coming down a little bit up, but more coming down. And we think that Gamma was a very good experience to this cross protection probably. And also the vaccination, but our vaccinations are not as high as in Europe. Yes, thank you.
Yeah, yeah. Well,
I would like to see your analysis with Gamma and South America.
Yeah, you know, I had only half an hour to do that, so I had to make choices. And actually, you're perfectly right. I didn't talk much about, you know, I don't know if there's somebody from South Africa. They could do the same complaint as yours. So what I can tell you is that in terms of, that's the reason why I came here. In terms of transmissibility, the alpha, beta, and gamma were kind of similar. And what we have seen is that there was a how could you call that? Seeding effect. When at the beginning of this circulation of the alpha, beta, gamma, you had first alpha or beta or gamma. That was the one that is going to expand, and the other one had difficulties to take place into these regions. And we have seen that in Europe, where alpha was predominantly circulating and there was no possibility for beta and gamma to take over. They could not take over. And it was exactly the opposite in South Africa, in South America, because there you had this, you had the gamma, and this gamma was circulating so much that the delta couldn't have a seeding effect that would help him to be installed there. And this is because the transmissibility, and it is really nicely shown here, of these viruses were almost equivalent. So in a competing effect, they were really matching. So it was really depending only on the size of the epidemic at the beginning, when the two are confronted to watch to each other, that allowed one or the other one to take over the other one. So clearly what we have seen in Europe with alpha, you've seen that with gamma, and the South Africa have seen that with beta. The second thing is that since the dissemination of this virus, you had an immunity, a herd immunity that has developed pretty rapidly. And this herd immunity, you know, it's interesting because it reduces not necessarily the number of cases, but the severity of the cases. And that is what we have seen in Europe for the countries that have been facing this large circulation of the alpha before, and for those that have been also pretty well vaccinated. Because when you look at the impact of the delta, actually, when you look at what happened in India, and what happened in Europe is not exactly the same. There was so many deaths in India at the beginning because there was no immunity. And so I'm not surprised that today, when you are facing the Delta, after this so big circulation of the other viruses, you would not see anything more. But when you look at the other lineages, like the Lambda or the Mu, actually they tend to disappear. They tend to disappear and they are displaced by the Delta. And the Delta is more transmissible, but not more dangerous than the other one. So if you see that in the concept of herd immunity, since you develop a significant herd immunity, you would see less severe cases, but you will see still the circulation of the virus. And if you want to prevent the circulation of the virus, you would need to vaccinate those that have been already immunized through infection. Otherwise, it will be circulating again. So that's my view on the beta and the gamma. They were nasty bugs. We were really afraid about these in Europe because we know that there's a immune distance. Even if they are not immune escape mutants, there's some immune distance with the vaccines, and we knew that the vaccine efficacy was a little bit less than what we did see with the alpha, for example. But you know, again, the Delta is immunogenically closer to the vaccine strains and is taking over now. So we hope that the Delta will not take some of the mutations we have seen in the Gamma and Beta to become an escape mutant and to evolve a bit more. So I don't know if I answered to all your questions and your remarks, but that's my views on the circulation of the Beta and the Gamma and how it will be in the future with the Delta.
Thank you. We have the last question.
Yeah, thank you very much for your presentation. Before we had a presentation about the immunity of people belonging to low classes. And we asked a question between the two groups that you presented before. You said that it is better to have antibody titers in those who have received vaccination and lower in those with infection. Did you have any other group, with a third group, with those who have already infected and received vaccination later? Thank you.
Yes. Yeah, absolutely. That's a very good question. I don't have the set of data here, but when you have been infected and if you have been immunized after infection, the level of antibody is over there. It's even higher. So those that are that have the best protection in terms of antibody are those that have been infected and then vaccinated at least once. These guys are those that are the most protective for themselves and for the others. So that's the reason why there's a kind of promotion of vaccination, even in convalescent people, because we know that that would induce very, very high antibody titers. I know someone which has 30,000 in terms of dilution of antibody titers, which is huge. And he has been infected, he has been doing a severe infection, and he has been vaccinated afterwards. So that's it is wise to do so, and it is good in terms of herd immunity for everybody to do it.
I'd like to ask you one key question. Thanks again for an excellent talk. I don't know if you had a chance to see my talk where I showed that it was predominantly Gamma, over 90%, and now the Delta is moving the Gamma away. That's the first thing, which is kind of surprising. The question I have is to make sure that we all agree that natural immunity versus vaccine immunity, natural immunity does not protect you as much against infection, but it does protect you against disease.
Yeah, I agree with you, because actually, when you do a natural immunity, you have the you install a B cell memory and a T cell memory with a CD4 and CD8 T cell memory, whereas with the vaccination you have a B cell memory and a T cell memory, which is only CD4 T cell. You don't have CD8 T cell. So in terms of protection, you have a wider protection in terms of immune component of the protection with the natural infection. But in terms of level of antibody titers, you have a better protection through immunization. And that's the reason why we have to combine the two to have the highest level of protection regarding all the aspects of the immune response and the immune memory. And I didn't catch, I couldn't see your presentation, but I didn't catch, you said that the Delta is moving Gamma out?
Yes.
Yeah. I'm not surprised about that. When you look at the level of transmissibility of the Delta, you cannot expect any other virus, previously circulating virus, to be sustained. That's not a surprise that the Delta is moving over everybody. It doesn't mean that there would not be some pockets where the virus may still be circulating. And once the Delta is somewhere, it expands and it displaces all the other viruses. It is so transmissible that, and there's so much advantage with that virus as compared to the other one that it's impossible for another one to be sustained.
You have an explanation for why poor people in Haiti, particularly those in the slums, get infected, but they don't get sick?
This is an excellent question, and absolutely, I don't know why. We know we look at that. There's some, there's this hygiene theory. I don't believe a second in that. I don't believe in that. But it is possible that there's some cross protection, and I'm wondering also if there's not somewhere a bias linked to the age in this kind of observation, because maybe the people living in the slum are on average younger than those that are not living there, and we know that age matters in terms of severity of the disease. So maybe we should look after that before saying that being in a non-hygienic atmosphere allows you to have a better immune response. Let's be sure that it can be true. I mean, I'm not sure, I'm not telling you it's wrong, but I'm not already convinced, because I'm not sure that the data we have to prove that is robust enough to be able to say that.
Thanks again. So thank you for this excellent presentation.
Thank you, and sorry for the false départ at the beginning.
Now we're going to move on to the next talk, wastewater-based epidemiology as a useful tool to track SARS-CoV-2. And it's going to be presented by Paulo Rizente from Brazil. Paula is a public health researcher based at the National Reference Lab, Influenza, Measles, and SARS-CoV-2 at Oswaldo Cruz Institute, Fiocruz, Rio de Janeiro, Brazil. She's a biologist with a master in tropical medicine and PhD in molecular and cellular biology, and she will entertain us about this topic. Please, you have the floor.
Thank you for introduction, Dr. Papi. Good morning, everyone. Today, I'm talking about the water-based epidemiology as a useful tool to track the SARS-CoV-2 and support the public health policies. May I change the slides with this one? And I click. Okay, so I separate my presentation in three main topics. The first one to talk about the concept of the wastewater-based wastewater-based epidemiology. After this, how the Brazilian Ministry of Health is organizing the structure to monitor this surveillance. And the third, our experiences in doing this type of epidemiology and surveillance in the field. So the first one, we know that this type of epidemiology is used frequently to monitor infectious disease in populations, such as investigation the occurrence of polio, influenza, hepatitis, norovirus, and Ebola in the water. We know that infected individuals shed these pathogens in feces. And sometimes these individuals are symptomatic, but sometimes not. And in this situation, we can observe the presence of this virus in this environment. That possibility to detect fast these pathogens in the water can be used as a predictive tool to complement the public health efforts. The wastewater-based epidemiology has also been used to monitor the effectiveness of vaccination programs, and the data can provide daily snapshots what's happening in that place also, and that population. And we can investigate this kind of circulation in different sizes of populations. Here, talking about more the SARS-CoV-2 surveillance in this environmental, We know that the RNA from SARS-CoV-2 can be found, can be shed in feces in approximately 40% in infected people. So when a community are infected, we can do the human surveillance as we are doing, but also we can use this environment to track this kind of virus. So we can observe the virus in sewer shed or in polluted effluent, or also in wastewater treatment plants. And we can track a viral lineage, the introduction and spread of these lineages in that community. We can do a continued surveillance to identify local hotspot of this circulation in the population. And we can observe when is occurring the mitigation phase in that population too. So, and as I mentioned before, we can track this in different population sites, and some places that this kind of surveillance has been done is in hospitals, airports, schools, town, neighborhoods, and also in slums. In Brazil, we decide together with the Minister of Health, Fiocruz and Minister of Health, decide to implement since April 2021 a pilot project to do this monitoring inside the country. So the initial phase was from April to June, when we start to these discussions and start to structure the network. We did some trainings in the previous months, and now we are acquiring some equipment because we received some fundings to implement this surveillance. And the main objective of this pilot is strengthening of the environment surveillance disease with public health importance within the Brazilian public health laboratory network, because we have a structured network in Brazil based on the detection of pathogens in water. And it's not just coronavirus, but other viruses too in the future. So we are implementing all these laboratories. So we have in Brazil now these labs that are contributing with this surveillance. So in green are some local partners together, working together with Fiocruz, and they are being integrated inside the Ministry of Health surveillance. We have some central laboratories called LACENS in some Brazilian states that are helping to and learning how to do these analyses and how to do these procedures to investigate pathogens in water. And our laboratory in Rio de Janeiro, Fiocruz, in IOC, the Instituto Oswaldo Cruz, some laboratories are helping these other states to do this monitoring. So in this phase one, we are doing the implementation, the standardization and the decentralization of these techniques, such as the sample collection, viral concentration, viral RNA extraction, real-time, to do the real-time PCR, viral sequencing. The viral sequencing we are performing at Fiocruz, and data analysis together with all the partners. And other groups are invited to participate of this network too, together with the Ministry of Health. Talking about now about our experience to doing this monitoring in the early pandemic phase in Brazil, we did this surveillance in Niterói. And this project was coordinated by Marisa Mia Gostovic and Tatiana Prado, that lead this research in the beginning of this pandemic phase in Brazil. So Niterói is a town in Rio de Janeiro state, And this tau is divided in 5 main regions. And we have 95% covered by the sewage collection network, and around 516,000 people living there. And Niterói is connected to the capital, Rio de Janeiro, by this bridge, and is part of the metropolitan area of the Rio de Janeiro state. And here the study design that we performed from April to August 2020, in the beginning of the pandemic. And in this map, we can see the 5 regions and places where we collect some samples. In green, we can see a sewer pipe, 17 located around the region. And in purple, we can see sewer pipe that was in slum, in poor population that live in some region of the state. And also wastewater treatment plants, we investigate the presence of coronavirus there too. So weekly, we collected 12 samples in 12 different points of this map. And the methods to do these procedures was the first, the pasteurization of all the samples collected. And after this, ultracentrifugation, followed by RNA extraction. And after this, a real-time PCR using different targets. And after this, we did some treatment to recover viral RNA. So we did some depletions of other materials to try to recover a good material to do the genome sequencing. And as a result, here we can see the 5 regions in this table. And in dark blue, we can see the high viral load, the lowest CTs. And we can see highlighted in red that where we found the highest amount of virus circulating in the environment was in the top of the epidemic phase, in this early pandemic phase. After, and we can observe a high number of deaths between April, May, and June, death and number of cases in that region of Niterói. Another thing that was really good, and we continue until now doing this, was a dashboard, an online dashboard, where we can see the number of samples collected in the region of Niterói, and in red, how many samples was positive to coronavirus in that environment that that sample was collected. So we are performing this weekly and doing this monitoring. And we can see during the period of the study, 15 April, we couldn't detect the coronavirus in the water. But after this, some hotspots of this circulation appear in the town, and in June, more in the other region north. And when we sequencing this material that we recover from the water, we found the lineage B.1.133 in 3 of these samples. It's really important to mention that sequence this type of sample is really difficult, because there are some issues about the quality of this sample. But these three first one, we could recover a good coverage of the genome. The last one, we couldn't, so we couldn't define the lineage of this virus because we couldn't recover the signature of that lineage. And when we observe this lineage, B.1.33 in the wastewater, we can compare what was occurring in Brazil in that moment. In that moment, we had in the beginning of pandemic, two main lineages circulating in Brazil, 33 and B.1.28. But in the Rio de Janeiro state, we had B.1.33, the lineage dominant in Rio de Janeiro in this early pandemic phase. Here, just to show you other experience that we are having in other parts of the country. Here in the south of Brazil, we are performing in Porto Alegre some epidemiology surveillance in this environment, the same way that we performed in Niterói, and also in Manguinhos. Manguinhos is a neighborhood in Rio de Janeiro, and there are a lot, 133 communities like slums there, and their surface water is used for waste disposal, consumption, and recreation of the children that live there. So we are investigating this Farinha Timbó River, samples from the water from this river, and the Cunha Channel too. And we, in that map, on the other side, we can see the timeline and the detection of SARS-CoV-2 in the water in different points of this river. So the challenges, there are some challenges and benefits to use this type of epidemiology surveillance. The main challenges are the sensitivity of the test, because the volume of water that you are recovering to perform the surveillance can be different in different times, and it can mixture the balance of the detection in that population. So we need to collect frequently and to try to detect it. During the process of the extraction and detection of the virus, there are different materials inside this sample that can interfere in the detection of the virus, so can inhibit the detection of the virus. So it is a challenge to manage with this situation, and it requires a constant sampling to establish a baseline of this detection and compare with data about the human surveillance as well. Talking about the benefits, it's cost effective because it can do fast and in real time. It can be a predictive tool to detect this virus. NGS, the sequencing, can be used to detect that diversity inside the sampling. And this combination about the sequencing, clinical data about the population, and the environmental situation can help the people that administration, that take the decisions, take a good decision to manage the situation in that population. And here, just to finalize and to give you a message, it's important to have this type of surveillance in different parts of Brazil, because in Brazil, we are a really huge country and we have distinct patterns of SARS-CoV-2 circulation in our country. Here we can see the main variants of concern circulating in Brazil. I'd like to highlight the green part, that is the variant Gamma, and some sublineages of Gamma that appear after March 2021 in Brazil. We have, for example, in north of Brazil, P.1.4 and P.1.7 in blue, in yellowy blue. So the pattern in north was different in the other regions of Brazil. So we have different circulation of lineages in different parts. But we can see that when Delta variants appear in June, it take the whole circulation, especially in South region and Southeast and Northeast. And in Central West and North, it take a while until it dominates. Now we can see that Delta is dominating the whole country, but with the sublineages of Gamma, it take a while in some regions of Brazil. And I'd like to thank the opportunity to present here and all the collaborators that are working with us together with the Fiocruz Genomic Network to evaluate the circulation of these lineages and also to monitor these virus in environmental, in animals, and also performing the human surveillance. Thank you so much.
Thank you for this very interesting presentation. Because of time delay, we will hold questions until the next session, the next speaker.
Okay.
So I'm privileged to introduce Ana Teresa de Vasconcelos. She's an experienced researcher who will be presenting on the genomic surveillance in the state of Acre crossing the Amazonian borders. This will be by video.
Good morning, everybody. I'm so happy to be here by video. I hope in the next year I will be present in the Gabriel meeting. That is a pleasure to be with all of the friends that we had since more than 10 years. So first of all, the first thing that I would like to thank you, the Gabriel meeting and the Fundação Merrier for conducting this with us, this project. The next, please. So I will start for the acknowledgement. This work I will present here is a work that has been developed under the Corona Omics network. This is a network coordinated by the Ministry of Science and Technology in Brazil, support from many different agencies, and also due to effort from the Centre d'Infectologie Charles Merrier, le Laboratoire Rodolphe Merrier, that is sending the sample for us in collaboration with the LACEN Acre. LACEN is a central laboratory distributed in many parts of Brazil. In this case, the LACEN, that's a public health lab in the state of Acre. So I would like to start to thank you all the partners that are involved in this task. The Corona Omics network is a network that is spread all over the country. We had more than 16 or 17 labs distributed all over the Brazil. So the next one, please. So I will start to talking about the state of Acre. State of Acre is here in the north of the country. It's a border with two countries, Peru and Bolivia, and the biggest two states, the Amazonian state and the Rondônia state. It's not for Brazil. Acre is not a big state. He has an area estimating 4,100 kilometers. And the estimated population is 906 million of people in this year. It's estimated data. The state of Acre is divided in 22 municipalities, and one important thing that he is living there 80 indigenous peoples in this small state that's covered by the Amazonian forest. Until 2019, Acre still had 8% for the original intact Amazon forest. More than 7 million hectares of Acre was designated for the protected areas. 5.3 million hectares are located in the conservated units, and more than 2-3 million hectares for the indigenous lands. But after this new government in Brazil, we have seen a huge problem with deforestation, as we know by the press. And between the August 2020 to July of this year, Acre saw more or less 1,000 kilometers of Amazon rainforest disappear. So it's very important to have the Laboratório Rodolfo Merrier in Acre to identify and to see and to study the virus and the molecular and other study to identify the environment of this area. And I think I'm so happy to collaborate with the Laboratório Rodolfo Merrier, and I would like to thank you again for all the effort for the Fundação Merrier to try to move on for this lab. So continuing my talk, I would like to next slide. So this is the situation of the state of Acre since the beginning of the pandemic in Brazil. We can see more or less in Brazil for 3 waves. The first one at the beginning was, as Paola told you, the predominance were the 2 main lineage, B1.128 and 23. After we follow by VOI, name is Zeta, is known by the P2 that was discovered in the beginning at Rio de Janeiro. And then Gamma dominated the country for the beginning of this year until last June, when the Delta appears in Brazil and is dominant at the moment. So the state of the Acre has a number, the 8,000 number of cases, 18 deaths. But in Brazil, we have a program, a national immunization that started in the 80s, and it's a well done. It's working very well. So at least in the state at Acre, we have 60% of the population vaccinated with 1 dose, and the full vaccination is more or less about 40%. And here in Brazil, we start the booster dose, and in the state of Acre, we have 6,000 dose at this moment. So I think that I agree completely that the Delta is not increasing so much in spite of his high transmissibility, because we start to have a good vaccination program in Brazil. So the next one, please. So this study is a collaboration, as I have told, with the Laboratório Merrier de Lacen et al. Of Acre. So we collect samples for 285 participants with PCR positive for COVID-19. The sample was collected randomly, and we try to take in account the larger number of the municipality in different parts of the Acre. The Rodolfo Merrier sent to us at Rio de Janeiro. My lab is located in the city of Petrópolis in Rio de Janeiro state. And the library was constructed at the lab using the QIAGEN kit. And after we sequence using the MiSeq Illumina at the lab. The next, please. So the period we collect an entire period. We decide to perform this study since the beginning of the year when the gamma start to appear in high number in Brazil, and we are sequencing up this moment, and I hope to have more sequence in the next future. So the Rodolphe Merrier lab sent in 3 different moments, the 95 sequence correspond the period from the January until April and then until July. And now we received last week, we finished the sequence last week, last Wednesday, until October of this year. The CT range varied for 13 to 29, and the age of the participants is from the 6 to 7 years old, and more or less 50% are women and men. Next, please. And here's the, would you like to reinforce the importance from the Laboratório Merrier, because this is a snapshot from the GSAID from the last Saturday. And we have already deposited 119 genomes at GSAID. We will submit the next 95 genomes soon, next week. And then here you can see the number, the low number of the sequence from the state of Acre from Brazil. So this study has contributed for 82% of the sequence that has been submitted for this region in this platform, and this number will increase with the next submission that we will do soon. So it's the representative for this work for the states is very high. The next one, please. So this is the state of the Acre divided by the municipality. And here we can see the number of the case. And then, as I told you, you will try to collect the sample regarding the number of the case and the number of the inhabitants in each municipality. I would like to remember that most of the states is still covered by the Amazonian forest. So the number of people that live in this municipality is high difference. So most of the sample was from the capital, Rio Branco, that is in the blue here, the dark blue here in this part of the map. The next, please. So I made a summary from the 3 runs here. I try to explain a little bit better after, but this is the result for the first run when that means that from the January until April. And in this moment, P1 was dominant in Brazil and also in the state of Acre, and also the P2 that appear here in Acre and the Brazil, this strain disappear, this lineage disappear up to the moment. But it is important to see a state that's bordered with 2 countries that can, the lineage, the virus can enter quickly in the country, and we are able to discover, to identify this lineage B1.13048 that has not been described in Brazil. The first time we identified this new lineage entered in Brazil, and he appears in the first running and then disappear for the next one. Here's the result for the second run. We collect from sample from March until July, and we are able to see here the dominance of gamma and the P1 and the sublineage, other sublineage that start normally in Brazil, the lineage start in the southeast of the country, mainly in Rio de Janeiro and São Paulo, and then spread all over the country. And here we can see that the gamma is dominant, but we are able to identify the VOI lambda C37 that's appear here in the States, in Acre. I would like to remember that the Acre is border with the Peru or Bolivia, where this voice is dominant. And the last sequence that we finished last Wednesday, we still have sequence from the beginning of January, because I would like to have sample from the more distant part of the state of Acre. We identify the B128 that was predominant in this time in Brazil, but most of the sequence is P1, and we identify the Delta lineage that arrived in Acre recently. I will show the results of this data next, please. So regarding all the sample, this is a simple tree that we didn't have time to perform all the phylogenetic and dispersion analysis with all the samples together, but we can see that this is the main lineage that is circulating in a state of the Acre since the beginning of the year. The predominance of the gamma lineage is predictable because the gamma dominated the country from January until June of this year. And then now we start to identify the Delta arriving in the state in the northeastern of the country in the state of the Acre. And we identify two sublineage of Delta also in this random sample collection. The next, please. Regarding, I will present divided into to analyze, because we're still rerunning all these trees with the third run. So this is regarding the first and the second, and the evolutionary relationship with gamma. Here we compare, we collected some samples, representative sample from the country that's bordered with Brazil or the state of the north of the country. And we can see here that we had at least 5 transmission between March and mid of March of this year. So in red is the sequencing that we have done in this work in the state of Acre, and we can see here the transmissions of the gamma. The next, please. When we analyze the dispersion of the gamma 1 with the national here in this map, the national transmission, or here the international transmission, I don't know if we can see here that we have here the state of Acre, and we can see that probably the beginning of the transmission, the dispersion of the gamma occur in the last year, in the end of the last year, more or less in December of the 2020. So here we can see the transmission of gamma across all the other countries in the southeast, in South America. And here we select some samples. I remember that the first identification of gamma was in the city of Manaus, the state of Amazonas, that's here. Then he spread fast for other states and the country. So it's very important to have access to sample from the states that may border with another country to identify the lineage that are coming from other countries. The next, please. Here related to the lambda, to avoid the lambda that we identify in the second run, and we are able to to identify 2 entries in Acre state, one probably in the end of 20, and the second in the January of 21. And we select the samples from the main countries that the Lambda has been described in the past. The next one. And when you look at the dispersion of this lineage, we using only the country, we can see that probably the first introduction arrived in December of the 2020, probably came from the Peru, The next, please. And now we are finishing with the sequence from the Delta. We identified the Delta lineage in the third run. It has been sequenced. You use here representative samples from all the states of Brazil, where the Delta is spread all over the country. And the next, please. And doing a zoom in these three, we identify that probably we have 4 main entrants for Delta in the state of Acre. Here we can see that for the age of these three, we have already dated the samples. This arrived in middle of September. Here we cannot see we only have it's not correct here. Is in the beginning of June. We have only one sequence, so we cannot confirm that. But we have another entrance in end of July and another one that's probably in the beginning of September. The next one. So all of this data are integrated we are analyzing all of this data, putting together all the 3 runs. We are redoing to all the dispersion analysis, taking in account the countries that borders with the state of Acre and the main state, Amazonas and Rondônia, to identify the entries of each lineage in the country. All of this data, you can pass fast. All of this data, we are in the database where the people, you can change the slides, please.
Now, could you move a little more quickly because we're a little short of time?
Yes, it's quickly. And you can upload quickly. You can go fast. And you can send all the samples. We could go. So all the things are arranged in a database, and so you can have the epidemiological data, the information for the patient, age, comorbidity, CT values. Continue, please. And also you can have the location of each sample, which lab has submitted, is sent to us the sample. Continue. Continue and continue. And you can see all the SNPs that are present in each sample, and you can identify the mutation, the SNPs that appear in each genome, and continue. And you can also look for the coverage and the quality of each genomes. So I would like to, the next one, please. I would like to thank my group that work at LNCC. This is a picture of part of the group, but I really would like to thank you, Daniel da Mata, that's the person that sent to organize all the data. That's the person that's in charge of Laboratório Mernier, state of Acre, and the team from the LRM at Acre that I'm proud to work all of them. Then are collecting and analyzing and send to us all this data. So is that, thank you very much.
Thank you for this very comprehensive presentation. I'm sorry that I had to rush you on this. Because of time, we'll only have one question for each speaker. Any? Yes.
I have Jean-Luc Berland from Fondation Mérieux. I have a question for Paula. To implement the wastewater epidemiology, you need to go beyond the laboratory. So how difficult is it to go beyond and to, I don't know, to seek the people from the wastewater plants? Or how difficult is it? And was it difficult, very easy? So
thank you so much for your question, Jean-Luc. But yeah, it's really difficult because we need to talk with this secretariat in each town, in each region, and try to collect, and this type of collection to arrange people to go to the field to collect it also is difficult. But in Niterói, and together with the Minister of Health and the Minister of Environmental, we are trying to arrange it in the best way. So in some regions that I showed in that map, we are deal with this kind of thing, and we are doing in a good way. We can do this. We are doing the surveillance, the continuous surveillance in that regions, but it's really difficult.
Any question for Ana? Yes.
Hello, Ana. Hello. Bom dia, tudo bom?
Daqui. Daniel.
So I would like to say thank you for your work, because if without that data, Brazil, Acre couldn't know which is the most important variant we had there, first gamma. And I don't know if you have the chance to see of course you had what you have in Haiti or in Haiti. So I saw, by my own experience, I saw a lot of Haitians leaving Brazil and going back to Haiti. Or what do you think that this immigration is important to spread the variants? But in this specific case, I want you to say about this experience, what you saw in Brazil, and spread out not only in South America, but to Central America and the Caribbean.
Yeah, we decided to do this study from the countries which make border or are in South America, but we have always a problem of sampling. So some countries we didn't have many the quantity of sample that we can analyze. But I will try to do that, to look at the available sequence that we have from Haiti. I think it's a very interesting experience. I think we have to move on this direction to see what we have in this moment from the Haiti. From my previous experience, we have performed surveillance in many different parts in Brazil, mainly in the state of Rio de Janeiro, but also in some of sublineage that we have been described in Rio de Janeiro. We published some papers that we can see this sublineage in another country. So the way that we are traveling a lot this common that this lineage or sublineage is important. And I think that we have to really focus from the borders of the country, and mainly in the Amazonian forest. But Amazonian forest is a reservoir for so many viruses, so many bacteria, so many things that you have to study. So you have, Daniel, the opportunity to guard this information for the whole humanity to study this. So thank you very much for you and your team.
Thank you.
Okay, thank you. So this will conclude this very important session. I think that we should summarize briefly by indicating that Bruno Lina gave us a very comprehensive talk on the origin of the pandemic, starting from the very early days, and particularly indicating that we're still looking for intermediate host for the SARS-CoV-2 virus. It also indicated that it's found the virus is found in many animals that could potentially, if they have the suitable host, jump into humans. Now, what I think it's important is the fact that there are still so many unknown about his presentation in terms of what will be next, in terms of the next phase, how long will it last, etc. The other important thing, take-off message is the rapid spread and dominance of the Delta variant all over the world. And the issue of the fact that vaccine seems to protect better against infection than natural disease. We also had a very important talk on the wastewater epidemiology, how it is used to predict potential epidemic by multiple virus. And now the last talk by Anna on the genomic surveillance that spread across